Today we're going to talk about heart physiology across the major domestic species, but instead of memorizing random heart diseases, I want you to think about one question: what is the heart failing to do? Is it failing to fill, failing to pump, leaking backward through a valve, conducting electricity abnormally, or being compressed from the outside? The basic physiology is the same in every species. Cardiac output is heart rate times stroke volume. Stroke volume depends on preload, afterload, and contractility. Preload is how much blood returns to the heart. Afterload is the pressure the heart has to pump against. Contractility is how strongly the myocardium squeezes. Then the electrical system controls timing. The SA node starts the impulse, the AV node slows it down, and the His-Purkinje system spreads it through the ventricles. Most heart diseases are just one of those pieces breaking down. In dogs, the classic heart disease is degenerative mitral valve disease, especially in older small breed dogs. The mitral valve becomes thickened and leaky, so every time the left ventricle contracts, some blood goes backward into the left atrium instead of forward into the aorta. At first the heart compensates by enlarging, but eventually pressure backs up into the pulmonary veins and the dog develops left-sided congestive heart failure, cough, increased respiratory rate, pulmonary edema, exercise intolerance, and sometimes a loud left apical systolic murmur. Treatment is physiology-based. Furosemide removes excess fluid from the lungs. Pimobendan helps the heart squeeze and reduces vascular resistance. ACE inhibitors such as enalapril or benazepril reduce maladaptive RAAS activation, and spironolactone can help counter aldosterone-driven remodeling. Pimobendan is used for canine congestive heart failure caused by myxomatous mitral valve disease or dilated cardiomyopathy, and it is also used to delay onset of heart failure in stage B2 preclinical mitral valve disease. The other major dog pattern is dilated cardiomyopathy, especially in large breeds like Dobermans, Great Danes, Boxers, and Irish Wolfhounds. Here the problem is not a leaky valve first, it is a weak, dilated ventricle that cannot contract normally. So the dog may present with weakness, collapse, arrhythmias, or signs of congestive heart failure. You treat the failing pump with pimobendan, diuretics if congested, ACE inhibitors, and sometimes antiarrhythmics depending on the rhythm. In dogs, I also keep heartworm disease in mind because Dirofilaria immitis lives in the pulmonary arteries and can cause pulmonary hypertension, right-sided heart strain, cable syndrome, and exercise intolerance. That treatment is not just give a heart drug, it is staged adulticide therapy, macrocyclic lactone prevention, doxycycline to target Wolbachia, exercise restriction, and careful management of thromboembolic risk. In cats, the biggest heart disease is hypertrophic cardiomyopathy. The physiology is different from the dog. The cat's left ventricle becomes thick and stiff, so the main problem is diastolic filling, not weak squeezing. The ventricle may contract strongly, but it cannot relax and fill normally. That raises left atrial pressure, and cats can go into pulmonary edema or pleural effusion. A cat may look fine until suddenly it is open-mouth breathing, hiding, hypothermic, or in respiratory distress. Cats with severe HCM can also form a left atrial thrombus that embolizes to the terminal aorta, causing painful hindlimb paresis or paralysis, cold limbs, and weak pulses. Echocardiography is the key diagnostic test, and NT-proBNP can help support suspicion when echo is not immediately available. Treatment in cats depends on presentation. If the cat is in heart failure, oxygen, minimal stress, and furosemide are the first priorities. If there is a large left atrium or previous thromboembolism, clopidogrel is commonly used to reduce thrombus risk. It is used to prevent left atrial thrombus formation in cats with HCM and left atrial enlargement, and evidence supports it over aspirin for preventing recurrent thromboembolism after a clot event. The big mistake with cats is treating them like small dogs. Cats with HCM are preload sensitive. Too much fluid can push them into pulmonary edema, but too much diuresis can make them hypotensive or worsen kidney values. Hyperthyroidism and systemic hypertension can also cause or worsen cardiac remodeling, so blood pressure and thyroid testing matter. In horses, physiology is dominated by a huge heart, high vagal tone, and athletic demand. A horse can have a rhythm that sounds alarming at rest but becomes normal with exercise. The classic example is second-degree AV block. At rest, the vagus nerve slows conduction through the AV node, so you may hear a dropped beat. The clue that it is physiologic is that it disappears when the horse trots or becomes excited. That is very different from a pathologic block that persists with exercise or causes weakness, collapse, or poor performance. The major equine rhythm disease to know is atrial fibrillation. In horses, atrial fibrillation can occur even without severe structural heart disease, partly because the equine atria are large. The atria stop contracting in a coordinated way, and the ventricles receive irregular impulses through the AV node. The horse may show sudden poor performance, an irregular rhythm, and sometimes no obvious signs at rest. Treatment is often rhythm conversion, either with quinidine sulfate or transvenous electrical cardioversion, depending on the case and facility. Quinidine sulfate is specifically used for atrial fibrillation in horses, but it requires monitoring because antiarrhythmics can be proarrhythmic and can cause toxicity. Horses can also develop murmurs from valve regurgitation, and bacterial endocarditis is possible, often needing blood culture, echocardiography, and prolonged antimicrobial therapy directed at the organism. In cattle, the heart disease I think of first is not usually primary cardiomyopathy. I think about infection, inflammation, and the anatomy of the reticulum sitting close to the diaphragm and heart. Traumatic reticulopericarditis happens when a cow swallows sharp metal, the object sits in the reticulum, penetrates forward, and can introduce infection into the pericardial sac. Now the heart is not just failing as a pump, it is being squeezed by infected fluid and fibrin. Clinically, you may see fever, muffled heart sounds, jugular distension, brisket edema, tachycardia, decreased production, and signs of pain or hardware disease. Treatment early may involve a magnet, broad-spectrum antibiotics, confinement, and sometimes surgery or drainage, but once septic pericarditis is advanced, prognosis is poor and humane/economic decisions often become part of the discussion. Cattle can also develop bacterial endocarditis, often after a chronic infectious source such as metritis, mastitis, foot infection, pneumonia, or jugular catheter infection. The organism may seed the valve, especially the right-sided valves, and create vegetative lesions. The physiology is a mix of valve leakage, emboli, chronic inflammation, and sometimes right-sided heart failure. Agents can include Trueperella pyogenes, Staphylococcus, Streptococcus, and other opportunists depending on the source. You treat the source, culture when possible, choose long-course antimicrobials based on likely organisms and food animal rules, and remember that severe valvular damage does not reverse just because the bacteria are killed. In pigs, a major cardiac concept is sudden death or poor growth from herd-level disease rather than a single pet-style heart murmur workup. One classic disease is mulberry heart disease, which is part of the vitamin E and selenium deficiency spectrum. Vitamin E and selenium act as antioxidants, so deficiency allows oxidative injury to muscle, including myocardium. In pigs, this can cause acute death, hemorrhagic myocardial lesions, or heart failure-type signs, and treatment is really prevention. Correct the ration, provide appropriate vitamin E/selenium supplementation, and address the herd nutrition problem. Nutritional myopathy in ruminants and pigs is linked to selenium and vitamin E deficiency, with muscle damage occurring because those nutrients protect tissue from oxidative injury. Pigs also get infectious cardiac disease. Erysipelas reticulopericarditis, the agent of swine erysipelas, can cause acute septicemia and diamond skin lesions, but chronically it can cause arthritis and valvular endocarditis. That matters because the pig may not look like a simple heart case, it may be lame, febrile, growing poorly, or found dead. Treatment of acute outbreaks often involves penicillin-class therapy where appropriate, but control depends heavily on vaccination, sanitation, and herd management. Erysipelas reticulopericarditis is the cause of erysipelas in pigs, and chronic disease can include valvular heart lesions and sudden death. Now heart blocks tie all of this together because they remind you that not every heart problem is a pump problem. A first-degree AV block means the PR interval is prolonged, but every atrial impulse still reaches the ventricles. A second-degree AV block means some P waves do not conduct. In horses, a second-degree AV block at rest can be normal if it disappears with exercise. In dogs, it can be vagal, drug-related, or pathologic depending on the pattern and clinical signs. A third-degree AV block is complete AV dissociation. The atria and ventricles are no longer communicating properly. The atria follow the SA node, the ventricles rely on a slow escape rhythm, and the patient may collapse because cardiac output falls. In dogs and cats with symptomatic complete heart block, a pacemaker is the definitive treatment. In horses and food animals, treatment is much more case-dependent, and prognosis can be guarded. So the clean way to remember cardiac disease is this: dogs leak or dilate, cats thicken and clot, horses fibrillate or vagal block, cattle get infected or compressed, and pigs often show herd-level nutritional or infectious heart disease. Then connect that disease back to physiology. Is preload too high? Use diuretics. Is contractility poor? Think positive inotrope. Is the rhythm wrong? Diagnose with ECG and decide if rate control, rhythm conversion, or pacing is needed. Is the heart being compressed by pericardial disease? The fluid and infection matter as much as the myocardium. And if an infectious agent is involved, the treatment is never just heart meds, it is source control, culture when possible, antimicrobial choice, withdrawal rules when relevant, and preventing the next case.